It is time to start this webinar, and good afternoon to all of you. I am Peter Hojerbeck. I'm the CEO of Avidicare. We are the sponsors of this webinar, and we sponsor it because we believe and we know that there are proven techniques that really work and that really can help so many people in hospitals and clinics to succeed even better in their fight against airborne infections. And we're also here because the whole field is quite new when it comes to airborne infections to many people. So we wanted to share some knowledge about the latest research that is out there and the experiences gathered that we have gathered and that others have gathered, and share that with you today. And it is with pride that I also want to introduce our speaker today. Her name is Kathy Warye. She's actually very well known in healthcare. She was even named one of the 100 most powerful people in healthcare a couple of years ago. And that was awarded because of her influence in driving awareness about healthcare-associated infections. And that is, of course, a tragedy in itself and something we definitely want to avoid. And her knowledge in that area is really extensive. Many of you probably know her also from her 7 years serving as CEO of APIC, which is the world's largest infection prevention community. But after that, then she joined BD, serving as a corporate executive working with infection prevention for the company globally. And now she's running her own consulting firm. And as Kathy has done presentations in more than 20 different countries, I know we'll be in for a really fact-filled and quick fast ride. So buckle up because there will be a lot of things happening. And if you do have questions, you can just type them in all the time in the chat, and I will, as your moderator, take care of them afterwards. Kathy will be speaking about 45 minutes, and then there'll be some 10-15 minutes for questions afterwards. With that, please, Kathy, the screen is yours. We just need Kathy to turn on her mic.
Sorry about that. I lost my internet connection just as you started speaking, so I had to reload everything. So I hope that doesn't happen again. Thank you, Peter, for the introduction, and it's a great pleasure to have the opportunity to present this content to you today. I think that before February or March of this year, the topic of ventilation was really the purview of architecture and engineering. Even from the perspective of infection prevention, if you had adequate isolation capacity for your facility based on the pathogens of concern that you were dealing with and the incidents in your community, that was pretty much how you thought about it. You were good to go. Ventilation otherwise just was something that operated in the background. But with COVID-19, everything has changed. Ventilation is top of mind for everyone from, school administrators to restaurant owners to those who lead healthcare facilities. So it's changed everything. Another thing that's changed is that after decades of almost no innovation in hospital ventilation, there is now technology on the market that is going to enable us to meet this challenge and coming pandemic challenges in a much more effective way. So before I get started, I wanted to let you know that Avidicare did provide sponsorship for the development and delivery of the presentation. And as far as learning objectives are concerned, by the end of this program, you should be able to discuss recent respiratory outbreaks and the airborne route of transmission as a risk to patients and healthcare workers, to be able to describe how airborne bioburden contributes to environmental contamination and transmission of multi-drug resistant organisms, evaluate the current state of ventilation in high-risk locations, and review the science of temperature-controlled airflow technology. So before I get started, I just, we have different disciplines on the webinar today, and I wanted to do a little bit of level setting around definitions. The first being the modes of disease transmission, of which there are 4. There is vector-borne transmission, direct contact transmission, indirect contact, and airborne. So the vector-borne diseases are those that are transmitted through parasites, mostly mosquitoes, and that includes things like West Nile, malaria, Ebola. Direct contact is with infected secretions, excretions, blood, or bodily fluids, and these are the bloodborne pathogens. HIV, hepatitis B, and C. The next is indirect contact with contaminated items, patients, or the environment. And this is where transmission of a lot of multi-drug resistant organisms like MRSA, vancomycin-resistant enterococci, carbapenem-resistant enterococci, Clostridium difficile, where those multi-drug resistant organisms are transmitted. But environmental transmission was also implicated with the first SARS outbreak in 2001-2002. It is implicated with MERS, that is the Middle East Respiratory Syndrome coronavirus, which is circulating primarily on the Arabian Peninsula, although there has been a large outbreak in Korea, and the current SARS-CoV-2. Although evidence is emerging that the environment is not as much of a factor in the current coronavirus as it was originally thought. Then we have the airborne route. The droplet route includes influenza, pertussis, meningitis, the original SARS, MERS, and the SARS we are seeing today. And then the airborne aerosol route, which would include TB, chickenpox, Mycobacterium chimera. This pathogen was responsible, epidemiologically linked to infections of cardiac surgery patients. They were infected when M. chimera was aerosolized from contaminated heater-cooler units. These units were contaminated in the manufacturing process. And is an example of a really devastating aerosolized transmission event. And then SARS-CoV-2, which evidence is emerging around aerosol transmission. So virus transmission can occur via direct contact, indirect contact, on deposited objects, and through airborne routes. So I think that the infectious disease community and the aerobiology community have kind of communicated a confusing message when it comes to the airborne route of transmission for COVID-19. As though droplet and airborne are two different things, when in fact, the way to think about this is that they are all part of a continuum. Where droplets are significantly larger, they are subject to gravity. They settle on surfaces quickly, typically within 3 feet of the source, and they contribute heavily to environmental contamination. Aerosols are on the other end of the continuum. They're significantly smaller. They're small enough that they can be suspended in the air. They can travel long distances, and they can remain infectious for long periods. Now, the reason infectious disease refers to droplet and airborne as theoretically different things has less to do with the airborne route of transmission than it has to do with how they distinguish between respiratory protection. So when a pathogen is droplet transmission, typically a surgical mask will suffice, whereas when it is airborne, meaning smaller particles, aerosolized particles, that's when N95s are more often recommended. So I just wanted to kind of clarify that because droplet and aerosol are all part of the same airborne continuum. So infectious particles can be generated from persons, heating, ventilation, air conditioning systems, cooling towers, and infection preventionists know well how it can be exacerbated during hospital construction. So I think where the infectious disease and aerobiology community are eventually going to land with regard to COVID-19 transmission is that the primary route is through small particle aerosol transmission, or SPAT. And in SPAT, viruses can remain suspended in aerosols and travel pretty significant distances, as much as 6 feet. The viruses can be released during exhalation, talking, coughing, in microdroplets, small enough to remain aloft in the air and able to pose a risk of exposure at distances, once again, of 6 feet or more from an infected individual. I saw a study the other day that suggested that these viruses may remain infective at 15 feet. These viruses have been shown to remain infectivity in droplets of this very small size. So in terms of aerosol transmission of SARS-CoV-2, I think whether it's droplet or aerosol, there's a good case for improved ventilation. But I think aerosol is where people get significantly concerned about the transmissibility of these pathogens and the extent to which we can protect healthcare workers and patients. And so these two studies got quite a bit of attention. You may have seen them already. The first happened very early on, and it involved transmission in a restaurant in China, where the airflow direction was deemed to be consistent with the transmission. So of the 83 customers, 10 became ill. And in reviewing this study, CDC in the Morbidity and Mortality Weekly Report stated, virus transmission in this outbreak cannot be explained by droplet transmission alone. And then the next event was widely publicized here in the US. It had to do with choir practice in Washington State, where 61 people were attending. One was known to be symptomatic. 53 cases were identified. 3 people were hospitalized and 2 eventually died. Responding to that event, CDC stated that the act of singing itself might have contributed to transmission through emission of aerosols. So this was the first early evidence of the possibility that COVID-19 was transmitted through those much smaller aerosol sized particles. So what about persistence of SARS-CoV-2 in the air and the environment? The study at the top, once again, was conducted very early on, and this team looked at the difference in air and surface stability between the current SARS-CoV-2 and the original SARS-CoV-1, and found that the current SARS is more persistent and can still be detected in aerosols at 3 hours and may be persistent on surfaces as long as 2 days. I want to note that this study was performed in the laboratory, so most infectious disease professionals would not find this actionable, but these studies are still very important in terms of informing our understanding of how this pathogen is behaving. So moving on to studies conducted in the healthcare institution. Early on in Wuhan, China, a team there looked at the aerodynamic characteristics of the virus and concluded that a direct source of SARS-CoV-2 may be virus-laden aerosol resuspended by the doffing, the removal of personal protective equipment, and through the cleaning of floors and the movement of staff. Okay, so at the University of Nebraska, which is one of the US's several high-level biocontainment units, they wanted to look at whether the virus was present in the air and the extent to which that virus had viable infectability. And so in the first study, they tested surface and air samples for the presence of SARS-CoV-2, where patients testing positive were being monitored. And they found that 63% of the in-room air samples were positive. In patient rooms, air collectors positioned more than 6 feet from these patients yielded samples positive for viral RNA. And I will say that RNA is not the same as virus capable of infectivity. But what really got my attention was the 58.3% of hallway air samples that were positive. So these were hallways outside of isolation rooms. And if any percent of that is positive, particularly in the event of us not having adequate personal protective equipment, this really got my attention around the safety or lack thereof of healthcare personnel. So this team concluded that virus expelled from infected individuals, including from those who are only mildly ill, may be transported by aerosol processes, potentially even in the absence of cough or aerosol generating procedures. So then that team moved forward to do the second part of the study, which is what I was waiting for, to identify whether or not those positive samples actually had viable virus. So they sought out to characterize the presence of SARS-CoV-2 in particles consistent with the potential to result in aerosol transmission between patients. So they found that in fact there was, and this goes back to the first study, SARS-CoV-2 that existed in respired aerosols. And they found that some fraction of the RNA containing aerosols did contain infectious virions. And their conclusion was that aerosol prevention measures should be implemented to stem the spread of SARS-CoV-2. I think this was probably the most definitive study up to this point in time calling for aerosol transmission prevention. And then a follow-up to that was conducted by the University of Florida, which is part of the CDC's Emerging Infections Program. They were also looking at viable SARS-CoV-2 in the air. And their aim was to evaluate the presence of viable virus in clinically generated aerosols. So this is just patients breathing, coughing, that type of thing. This is not in the event of aerosol generated procedures. This is clinically generated aerosols via air samples from rooms with 2 COVID-19 patients. So they found that viable virus was isolated 2 to 4.8 meters away from the patients. They found the genome sequence of the strain from the air samples identical to that from the isolated, newly admitted symptomatic patients. They estimated the viable viral concentration to be, reasonably low, but that did not really impact their warning here. They stated that patients with respiratory manifestations of COVID-19 do produce aerosols that contain viable SARS-CoV-2 in the absence of aerosol generating procedures, and that airborne aerosol transmission of viable SARS-CoV-2 is likely and plays a critical role in the spread of COVID-19. So before I leave the COVID-19 section, I wanted to leave you with several quotes. The first two really regard the future, and they're both from Tony Fauci. In the first, he said that SARS-CoV-2 is an airborne, highly efficient spreader that is here to stay. And in the second, he said SARS-CoV-2 will not disappear like SARS-CoV-1. It is such an efficient spreader, there will always be emerging and re-emerging infections with COVID-19. So as I think about our resilience moving forward, I think about the fact that this is something that's going to be with us for a very long period of time, and that we need to be prepared to address it in its emerging iterations. And the final comment came from that highly publicized commentary from the 239 scientists who appealed to the WHO to recognize that there is significant potential for inhalation exposure to viruses in microscopic respiratory droplets at short to medium distances, and their advocacy for the use of preventive measures to mitigate this risk of airborne transmission. So I wanted to go back just a bit to share this study with you on the SARS-CoV-1 outbreak, because I think it presents a really interesting visual as we think about the impact that better ventilation could have. So this was an outbreak at the Prince of Wales Hospital in Hong Kong. They treated one patient, which led to an outbreak of 138 probable cases. And what they looked at was the extent to which the bioaerosol distribution in the ward agreed with the spatial infection pattern of the SARS cases, and determined that the predicted bioaerosol distribution did agree fairly well with where those SARS cases ultimately emerged. So if you look at these two illustrations, on the left, you see the index patient and the dark area being the highest viral concentrations. And on the right, you will see where those cases ultimately emerged, and how similar those two illustrations look. And I can only wonder with better ventilation if perhaps some of that transmission might have been mitigated. So viruses are not the only reason we should be concerned about cleaner air. Airborne contamination and environmental reservoirs are significant contributors in the transmission of multi-drug resistant organisms. And in addition to the pandemic we're having today with COVID-19, we are also in the wake of a pandemic of multi-drug resistant organisms. The 4 studies on this page address 4 different multi-drug resistant organisms: MRSA, Clostridium difficile, and Acinetobacter baumannii. All 3 of those pathogens have been deemed by the CDC to be either urgent or serious public health threats. And so in about the 2005 timeframe, when C. difficile began to rise in incidence, CDC is spore-based, so it's difficult to remove from environmental surfaces. So US healthcare started to spend billions of dollars in environmental cleaning and disinfection. But of that, almost all of that investment and effort was directed at hard surfaces. Comparatively little, if any, was directed at the primary source of that contamination, or a primary source, which is the air. And even when healthcare workers diligently adhere to infection prevention measures like hand hygiene and environmental disinfection, that does almost nothing to mitigate the contamination risk from airborne bioburden. And that's because there is continual redistribution of microbes that occur at the air surface nexus. Once those surfaces have been decontaminated, they're immediately reinoculated by the air. So in the first study, investigators looked at how MRSA infected or colonized patients contaminate their rooms and how that might contribute to MRSA, which is endemic in US hospitals. This was a prospective study of 25 patients. Their sampling indicated that 53.6% of the surface samples were positive, 28% of the air samples were positive, and 40.6% of the settle plates were positive. And the isolates were identical or closely related in 70% of the patients. So those patients were contaminating the air and the environment around them. In the second study, after bed making, MRSA counts remained elevated for up to 15 minutes. And in the third study, investigators wanted to look at the potential of aerial dissemination of C. difficile spores. So on 2 days in 2006, they cultured C. difficile from the air. They found 23 samples yielding the bacterium at mean counts of 53 to 426 CFUs, with 426 being, at the high end and, getting my attention. And they said that this pilot study produced clear evidence of sporadic aerial dissemination of spores, which may help to explain why Clostridium difficile disease is so persistent and difficult to eradicate. They said that current control measures may be inadequate, that the ventilation system was unable to purge the ward of air of C. difficile bearing particles, and that improved ventilation is suggested. The final study was one that identified a very clear association between the positive colonization status of a patient and the air colonization with Acinetobacter baumannii in the room. Now, when the Acinetobacter study was published, it was published in Critical Care Medicine. And two of the editors wrote a commentary that goes like this: "These findings are alarming and suggest that environmental decontamination focusing on surfaces will not fully prevent A. baumannii transmission. It seems likely that A. baumannii in the air above and around patients has the potential to contribute to infection transmission in several ways. By recontaminating surfaces in a room after environmental services personnel have disinfected those surfaces, by spreading organisms from one colonization site on a patient to multiple sites on the same patient as airborne bacteria settle out of the air, and by airborne contamination of healthcare providers' clothes and hands, even if adequate hand hygiene is done before patient contact." So where do we go with better ventilation for high-risk locations? At this point, I'd like to begin to introduce you to temperature-controlled airflow. And I'm going to focus for the next several slides on the operating room. Because TCAF was designed for the operating room, it can be configured for any high-risk situation where better ventilation is a concern. But because the data that we have comes from the operating room, I wanted to share that with you. But before we begin that, I wanted to kind of level set on a term, and that is ultra clean. That this is more than a branding slogan, that ultra clean has a specific definition in aerobiology. So when Sir John Charlie began his study in the late 1950s, he was able to reduce SSI after hip prosthesis surgery from 8.5% to 0.7% by reducing the colony forming levels, unit levels of bacteria in the air from 600 CFUs down to less than 10 CFUs. This was a large study where no antibiotics were used, and it clearly illustrated the correlation between CFU levels and SSI rates. Now, Lidwell confirmed this work in a very large prospective study in 1973. There were 3 arms to this study around antibiotics, air cleanliness, and clothing, but they were studied independently to determine the impact on SSI. They specifically set out to study the effect of ultra-clean conditions, fewer than 10 CFUs per cubic meter, versus conventional ventilation. And they found that rates of joint sepsis were 50% lower in ultra-clean conditions than they were with conventional ventilation. So what is the current state of operating room ventilation in the US? There are 2 forms, or 2 technologies. One is turbulent mixed airflow, and the other is laminar airflow. So with TMA, this technology is based on the dilution principle, where you mix contaminated air with clean air to reduce the concentration of bacteria. The key parameter is the number of air exchanges per hour. But what I find interesting is that the US standard is for 20 air exchanges per hour, and that does not achieve ultra clean conditions. Even at 60 air exchanges, you can't achieve ultra clean conditions with TMA. This is also the least energy efficient of the systems. And I think all you have to do is look at that diagram above to figure out, what's going on with the air in a TMA system, and that is suboptimal in terms of preventing infection. On the right is laminar airflow. So laminar airflow is based on particle entrainment, which is the ability to keep dirty air from entering the protected zone. This system relies on air direction and velocity, and it's intended to create a clean zone immediately above the surgical field. So this is a very limited ultra clean zone that's typically about 3 by 3 meters in size. It does not produce ultra clean throughout. It is capable of producing ultra clean immediately under that LAF ceiling. And I've heard recently people say that ultra clean doesn't work. And I think it's because laminar airflow has claimed ultra clean, but in fact, it's a very limited space. And this has real implications for surgical site infection, which I'm going to share with you. So what are the limitations of laminar airflow? Well, Benning and his team sought out to evaluate different ventilation systems and their impact on the contamination of medical devices. And they observed a 55-fold increase in the mean value of airborne CFUs outside of that limited protected zone compared to the value inside the protected zone. So on the right, you will see a computational fluid dynamics simulation conducted by the Royal Institute of Technology in Stockholm, modeling the airflows for laminar airflow. And you will see there that, in the blue, you have a lot of turbulence going on. You don't have any particular direction. And that laminar airflow is clearly challenged by the vortices in the corners of the room and outside of that strict ultra clean zone with that downward flow. It was the next study that really got my attention. So those of us in the SSI world know that it is absolutely imperative, the guidelines require, that anything that has previously been sterilized, an instrument, a device, an implant in particular, must be kept in that ultra clean zone. But a group of investigators in the Netherlands in this study called Safety by Design looked at the effects of operating room floor marking on the position of surgical devices within that clean zone area. So they used floor markings to evaluate the frequency of positioning of surgical devices within the clean zone. Prior to marking, they found that devices were in the clean zone in only 6.1% of surgeries. And then after marking, they were able to increase that compliance to 52%. So that means that in 94% of surgeries, 50 to 94% of surgeries, those items like implants for which a very small inoculum is required to create a devastating infection are not in the clean zone. So I think that really is one of the reasons why we're finding that LAF is not as effective as originally thought. And so there has been movement away from LAF. 2 systematic reviews and several national joint registry studies failed to show an advantage in reducing surgical site infection for hip and knee arthroplasty. And one study actually found an increase in SSI with LAF. So in 2003, before this evidence emerged, the CDC had recommended LAF for joint procedures. But then after the evidence emerged, they backtracked, classifying LAF as an unresolved issue. The WHO in 2017 went a bit further, issuing a conditional recommendation that laminar airflow ventilation should not be used to reduce the risk of SSI for patients undergoing total arthroplasty surgery. And then in 2018, the Prosthetic Joint Infection Global Consensus Group, and this is a group of 400 prosthetic joint surgeons from all over the world, concluded that LAF may no longer be recommended. Okay, so if that's what we were using previously, it was considered to be the gold standard. What do we do now? So at this point, I'd like to introduce you to temperature-controlled airflow technology. This technology is new to the US, but it has been installed in Northern Europe for over 10 years now. So TCAF was designed to minimize airborne contamination and achieve ultra-clean conditions throughout the entire OR. To improve comfort for surgical teams, we have some data on that as well, and to optimize energy use. So how does it work? Well, in TCAF, bacterial levels and air movement are controlled through a combination of a temperature gradient and gravity. So in this system, HEPA filtered air is dispersed from air showers at 1.5 Celsius cooler than the ambient room temperature. And you will see those gray pods, those 8 air showers in both of those pictures. The temperature gradient, because cool air is heavier than warm air, the temperature gradient drives the central vertical flow of cooled air downward, and it prevents those stagnation zones in the periphery that you see in LAF. The fall speed of the air is high enough to counteract body convection from the staff, as well as heat convection from the lamps and other equipment. So if there are any infection preventionists on this call, I can hear you saying, yes, but we need certain temperature to protect against neurothermia for our patients. And I want to let you know that the room temperature can be set at any level that you desire to ensure patient safety and staff comfort. You can set it at any level, but the air coming into that room is going to be 1.5 Celsius cooler to enable the TCAF airflow pattern. So how do LAF and TCAF compare? So back to these computational fluid dynamics simulations. And CFD is used frequently in aerobiology because it's a very effective way of being able to visualize and simulate airflow patterns. So here you have that same illustration on the left with laminar airflow, which relies on direction and velocity. You can see that it's very much challenged by the vortices in the corners of the room, and that downward flow is really achievable only in the, that limited area above the surgical field. On the right, TCAF in comparison, which relies on a temperature gradient and gravity, is better able to overcome heat convection and obstacles to maintain that ultra clean throughout the entire space. And you will see that that downward airflow is much more consistent in the TCAF simulation. But I have a couple of more visualizations to share with you. So the first two are, whoops, this one's getting ahead of me. The first two are with laminar airflow, and how laminar airflow is challenged by heat convection from lamps and people and obstacles in the room. So the first is a smoke study of a laminar airflow room. And you will see that the air moves up, 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 moves towards the heat source, which is the lamp, and then it flows downward. So there's an illustration of that kind of turbulent vortex. In the second video, the smoke is released underneath the surgical lamp, and you will see that the air moves towards the surgical lamp, swirls around, and then gets deposited on the surgical field. So I have similar videos for TCAF, and you will see how it navigates obstacles and maintains the downward airflow in a much more consistent way. So in this video, the figure in the middle is a real human. Whoops, just need to go back. And so in TCAF, the downward airflow is able to navigate around the human, keep the shedding of bacteria, which is the primary source of contamination in the operating room, keep that shedding of bacteria from the personnel flowing down and out. And in this study, you will see that TCAF beyond the surgical field is continually pushing that air down and out through the exhaust vents. And then there's one more simulation here with the surgical lamp and you will note that the air is continuously pushed downward. So HEPA filter air is coming in above the surgical field. Clean air is coming in above the surgical field, and because of temperature-controlled airflow, it is being pushed consistently down so that clean air is pushed down across the surgical field. Okay, so because TCAF has been installed in over 200 facilities in Europe, the Avidicare team has been able to conduct over 700 measurement events under a variety of conditions. So different numbers of surgical personnel present, different procedures being conducted at the time under various clothing concepts, and these measures were always taken in 3 locations. So you'll notice that on the average of those 700 measurements brings the CFU measurements well down below ultra clean in all 3 of the critical locations. So the average is at the wound, 0.4 CFU, at the instrument table, 1.5 CFUs, and in the periphery, 4.1 CFUs. Now on the right is a comparative study in a rather prominent US academic medical center. These measurements were taken during live neurosurgery and in multiple operating rooms. And you will see with the red bars that with the exception of the wound, the CFU concentrations were far higher. In this institution, they had 4 CFUs at the wound, still under ultra clean, but not as low as temperature controlled airflow. At the instrument table, there were 27 CFUs, and in the periphery of the room, there were 60. So the airborne contamination in the US institution was approximately 10 times higher than that in TCAF rooms. So here I'm gonna throw a little bit of theory at you. And just, kind of keep with me for a minute here. What does 10 times the amount of microbial contamination mean for outcomes? So the Lidwell estimated that if you had between 10 and 100 CFUs, that your SSI rate would theoretically be 1.8%. Now, this is the rate we claim here in the US, although we know that SSI rates are likely significantly underestimated. If you had a CFU level of less than 10 and maintained ultra clean, your SSI rate could theoretically be 1.2%. So maintaining that theory, if the US institution achieved ultra clean levels, a 40% reduction in SSI could be achievable. Now, I think this is important to consider because here in the US, we have done just about everything we can to reduce surgical site infection. And experts that I've talked to all agree that the opportunity for practice-related reduction in SSI is exhausted. At the same time, 2 to 4% of all patients undergoing inpatient surgical procedures will contract an SSI. And we know that prosthetic joint infections, for reasons that we're not quite understanding at this point, are going upward. So I think we owe it to our patients to look at technology interventions that may actually get us back on track in terms of being able to further reduce surgical site infections. Okay, so you may say all of these microbial measurements are great, but does temperature-controlled airflow really reduce SSI? So a pilot study was conducted to validate the clinical efficacy of TCAF and reduction of surgical site infection. This was a retrospective analysis of 1,000 consecutive cases of primary total joint arthroplasty before installation of a TCAF system and 1,000 consecutive cases after the installation of the system. Results were that surgical site infection rate decreased from 3.1% to 1%, as measured by a decrease in the number of readmissions and postoperative surgical treatments. And you can see that in figure 1. Mean postoperative length of stay was also reduced from 11 days to 8.64 days, and a decrease in the percentage of patients who stayed inpatient over 14 days from surgery went from 7.3 to 2.2. And you can see that in figure 2. So the investigators concluded that these studies, taken together with the evidence demonstrating reliability of TCAF and elimination of airborne bacteria, suggests that implementation of TCAF presents a new opportunity for reduction of surgical site and prosthetic joint infection. I'll also note that this study was conducted completely independently. There was no funding provided by Avidicare, no influence in the design or implementation of the study or in the analysis of the outcomes. So TCF is very flexible. There are some pictures here that convey, that it can be configured in any kind of surgical configuration. And on the bottom of the slide are configurations in surgical prep rooms, where I think we also have to do a better job of protecting healthcare workers from hazardous materials. So TCAF can also be configured for any high-risk area. And here are some visuals on TCAF in a pharmaceutical laboratory, in a radiology area, and in a central sterile supply department. And while it hasn't been implemented in intensive care or emergency departments, I think that in light of our current situation and the fact that this is not going to be the last, respiratory pandemic we face, that we should really consider this for intensive care units, emergency departments, where aerosol generating procedures put healthcare workers at risk, potentially outside of isolation rooms, and maybe even in some other places. So because there is real limitation to ventilation in other high-risk areas. Isolation rooms are well protected, but with a virus like the one we're dealing with today, we also need to think about how best to protect healthcare workers. And the ventilation in all of these other areas is based on slow dilution. It's so similar to that TMA mixing of air with a prescribed number of air exchanges. And even if you escalate the number of air exchanges and you're bringing in more clean air on a more frequent basis, there is no downward flow to that air. That air is still essentially just bouncing around the environment, and that can spread airborne contamination. And this puts healthcare workers and patients at risk of transmission. So we know why we should care. At the front lines, our healthcare workers are at risk. In the first SARS outbreak, there were a total of 8,000 cases, of which 1,700 were among healthcare workers. That was 11 to 50%, 57% of cases, depending on the outbreak. And with COVID-19, we don't know how many healthcare workers have died. The CDC data has not been updated since May. And they will state on their website that their data collection methodology has underestimated transmission and deaths. I think part of that is because it's very difficult to get this information, and I can certainly provide that methodology to you later on if you're interested in it. But the Amnesty International has also looked at this. It estimates that US deaths to be the second highest in the world at over 1,000. And this was July 13th, so this is old data. Kaiser Health News and The Guardian estimated back in July that 703 US healthcare workers had likely died of COVID-19. And my understanding is that they have 900 cases under investigation today. Now, if you wonder whether healthcare workers are really getting it in the healthcare setting or someplace else, the government in the state of Victoria in Australia conducted an analysis that showed that up to 80% of the almost 2,700 Victorian healthcare staff who tested positive were infected at work. And I think we can't overestimate the burnout, the loss of psychological safety, and the stress that healthcare workers are suffering at this point in time. This is also not the last pandemic we're going to be dealing with. Influenza pandemics still occur from time to time. These are aerosolized events. It's easily spread. And while healthcare workers largely are vaccinated now against influenza, it hasn't prevented HAI transmission. And then we have the Middle East respiratory syndrome that I spoke of earlier. Right now, it's contained primarily to the Arabian Peninsula, although, as I said, there was one major outbreak in a hospital in South Korea. It's considered rare, but the mortality rate is very high. It's in the order of 34 to 37%. Today, it's limited to non-sustained human-to-human transmission. It continues to occur. It is mainly in healthcare settings. MERS is airborne, believed to be spread primarily by droplet. Although evidence of aerosol transmission is not conclusive, this route has not been ruled out. And according to the WHO, the risk of exported cases outside of Saudi Arabia remains significant. So we could have MERS on the North American continent at some point in time. And the frequency of outbreaks in general is increasing. So since the 1918 Spanish flu, we had about a 40-year break. between the 1958 and 1970 Asian and Hong Kong flus. And then we had another 40-year break between that and the original SARS outbreak. But that happened in 2002. Then in 2009, we had the H1N1 pandemic, which killed 200,000 people globally. Then MERS occurred in 2012. Case rate's still reasonably low. Death rate is only 858, but as I said, the case fatality rate is very high. And we have COVID-19, which emerged in 2019. So H2N2, the Asian flu virus, is still in circulation worldwide. The MERS coronavirus is still in circulation, although contained at this point, and SARS-CoV-2 is in circulation globally. So I wanted to leave you with just two more concepts. And this one is about how infection prevention and public health experts think about the hierarchy of exposure control measures. And so looking at this inverted pyramid, you'll see more protective measures at the top and less protective measures at the bottom. So the very most effective measures that can be taken are those across society to limit the spread and reduce the impact of infectious agents. So public health measures, like what we're seeing today with mask wearing and social distancing. But just below that, the second most effective measure is an environmental measure. So these are physical changes in the setting that reduce risk of exposure by isolation or ventilation. And way down at the bottom of that pyramid is personal protective equipment. So even when we don't have shortages, even when we're not trying to sterilize masks that are intended for a single use, PPE really is a suboptimal way of protecting our healthcare workers. So just one more thought. As I think about addressing the current threat and future threats, I think a lot about resilience. I think our healthcare workers have been tremendously resilient. It is remarkable the way in which they have been able to mentally and physically sustain through this crisis. But our systems and our ability to support them has been far less resilient. So if we look at resiliency as the ability to adjust functioning prior to, during, or following changes and disturbances so that we can sustain required operations in the presence of continuous stress, I think we have not done very well in that regard. But moving forward, the concept of resilience provides a means for organizations to target resource investments by integrating safety and productivity concerns. And I think that improving ventilation will improve safety, and that by improving safety, we can potentially improve the productivity and the mental and health well-being of our healthcare workers. So with that, I would like to turn it over. Oh, I'm sorry. The takeaways from this, that there is constant interplay between the air and the environment, that even when diligently adhered to, infection prevention protocols, include hand, instrument, and surface decontamination, do very little to stem the infectious potential of airborne contamination, that there is evidence of airborne transmission of organisms of concern, multi-drug resistant organisms in particular. SARS-CoV-1 was primarily spread via the air. MERS-CoV-2 is spread in droplet form in the air. And it's SARS-CoV-2 COVID-19, there is evidence of long-range aerosol transmission that is growing. It is a very efficient spreader, and it's here to stay. The frequency of outbreaks, epidemics, and pandemics, generally speaking, is increasing, that conventional ventilation may contribute to airborne transmission, and the TCF has been shown to be superior to conventional ventilation in reducing airborne bioburden in the operating room and in other applications, and that it can be configured in any location, offering a new opportunity for reduction of airborne bioburden in areas where risk of airborne transmission is of concern. So, with that, I'd like to thank you for participating today, and I'm going to turn it over to Peter for questions.
Thank you, Kathy. That was a lot of information. Also, of course, a lot of terrifying information. But we do this because we also know that there is hope. There are things that can be done to improve the situation as it is today, because it's such a difficult one for so many of us.